about two topics that we worked on the past 2 years a lot, that were very relevant in Gaza, sadly. One was about mortality estimation and another about starvation and the famine, and how our role as researchers, epidemiologists, could feed into what's happening, inform, in the middle of a lot of uncertainty. And this is common in wars in general, in Sudan, that we've tried now to use some of these methods also in Sudan, a conflict that is less shed light on, and I think is important to also focus on that the same methods are being also used to try to showcase what's happening there. So if you're interested, please look up these papers also. So my focus will be about, first of all, mortality. And I will go back 2 years ago. So 2 years ago, starting with mortality. So more than 2 years ago, I don't know if you remember, the president of the US said that he does not believe the numbers of the Ministry of Health in Gaza. And this actually happened right at the beginning of the war on the 26th of October. So 20 days after the start of the whole war. So as a response, the Ministry of Health in Gaza released a listing of the names of everyone that was killed, with the name, the gender, the age, and the ID. And something very important about Palestinian IDs is that it's actually every person in Gaza and West Bank have a series of ID identification that's very well recorded in a census, actually. And these have been used in previous wars and also in COVID-19 mortality. So it's not mortality only related to war. And so the ministry has released that list, and what happened as a consequence is we took these lists and we analyzed this data. One of the things we looked at was the ID, but the other thing that we also looked at as epidemiologists is to look at mortality rates. So in red, it's actually the mortality rate of the females, and in blue was the mortality rate of males by age, okay? And the light blue one that is very light here is actually before the war, which was a normal pattern of mortality where older people were more likely to die and the youngest also were more likely. So when we look at this pattern of mortality and we compare to healthcare worker mortality and to UNRWA staff mortality, and the UNRWA staff is actually the UN works in Gaza to provide a lot of assistance and has been doing that since 1948 in Gaza and West Bank. And so if you look at the mortality rates of UNRWA staff killed and healthcare worker killed, they actually look as they are overlapping the male mortality. And there was another analysis also that looked upon this. Now, of course, in wars, you're going to get different people looking at data and doing different analysis. So there was a statistician who basically looked at the correlation between women and child mortality and showed that there is no correlation. So that means this data is fake. And actually, the reality is that this is not how data is collected, because we know people are not going to collect on the same day, the same time, and the mortality of males and females and children. And actually, if you dig more into that data, he fabricated some of the numbers. And so you could actually find them and actually go. And so there was like a war between like, oh, this, what is really the mortality? Is this data correct or not? But also there were other people like Air Wars and other researchers and journalists who really dug into these numbers and names and to actually find them and find the list of people that were killed. But what happened actually also is that after a while, the UN has released this chart that created a lot of problems. Why did it create a lot of problems? Because it actually said that 36,000 people were killed in May, actually, end of May. Around 36,000 people were killed in Gaza, with actually only 24,000 identified. So we only had the names of 24,000. And then also at the bottom here, I don't know if you can see it, they said like only 10,000 were actually reported missing. So in this chart on its own, there is 3 different numbers. And the UN, they love their charts and they love their dashboards a lot. But actually, this created a huge confusion because then again, different audiences, journals and journalists were like, oh, but this means the number of the Ministry of Health is wrong because only 24,000 are identified. What is this 10,000 under the rubble? And what is this 36,000? And they did a huge press conference. And the reality is, and what happened, okay? Like any war in any countries, actually, Gaza had a very good health information system. And this is one of the big arguments into investing in health information system in all countries, regardless of any crisis later on, hopefully never having a war, but a drought or any of the big crises that can happen, or like an earthquake, is having good health information system helps you track mortality. And so what happened is that in Gaza, they had really good health information system that they were able to track mortality from the morgues. So in the hospital morgues, at the beginning of the war, they would get all the names and ID and age and sex and the location of where they were killed from data from the hospital morgues. And that is in dark blue. With time, what happened is Israel was attacking hospitals. So one of the big things that happened is that reporting stopped from hospitals. So you could see here that at a certain point in November 2023, 6 out of 9 hospitals were reporting. Then 5 out of 9 hospitals were reporting. Then 3 out of 9 hospitals were reporting. And then it picks up back again at 2, then 3. They were closing and opening the hospitals and closing and opening the reporting system, but also the internet was being cut. And so a lot of times the hospital data became less and less available. What then happened is that the ministry then decided after October, like in November mainly, to start complementing this data with unidentified media reporting. So journalists in a certain area says 5 people killed here. And so they add that to the total number. And this is where the idea that we had the names of identified people that were 24,000 in June, but in fact, we had unidentified people in gray. Now, what happened also is that the Ministry of Health decided that since we're seeing this patchwork of data coming, is that to start a survey where they ask relatives to report who was killed from their family to get a death certificate, okay? So then this is the light blue one, where actually they started to complement this data. So what reality was happening is that this list of people that were killed of 24,000 was actually from the morgues and from the survey data, and some unidentified by the media. Okay? And so, but we know that, we knew that there were 10,000 under the rubble, and we knew that there were some that were not identified, and all of that ambiguity that happens in war. And so we decided to use this method called capture-recapture. And this method has been used before in wars and has been used for the prosecution in the case of Yugoslavia, and has been also used in Colombia. And you will find a lot of papers and studies that try to use this method of capture-recapture. And it's actually quite old. It's not new. And recently it's been used in Sudan and to estimate mortality in Khartoum. And what does this method really entail? And I will be very simple. And if anyone wants more data, more details, we can discuss further. But also, happy to if it's not clear, so that I can repeat. So the idea behind it is that you rely on listings, okay? And that you have a list of people that were killed in one list, and you look at the overlap with another list from another place of the number of people that were killed, and a third list where you look at the overlap with the 3 lists. And the idea behind it is that you really want to identify how many were outside any of these lists, okay? And so if you want to think about it more simply, is that if you have a lot of people that actually were on multiple lists, that means that those that are not captured or outside of any of these lists would be less. And if you have less people that are overlapping between the lists, that means you would have more people that are outside of all of these lists. This is a very simple way of really showing this. But that's the idea. So you will have, this is basically you'll have less people overlapping. You have more people outside these lists. More overlap, you'll have less people. This is very, very simple. And then you'd actually fit in models. So like you would use Poisson regression, or you could use Bayesian or Bayesian models. And we've done in the paper different analyses, and they all show similar estimates. But what you do is actually you fit in multiple models where you look at the independence between the lists, and then you look at the interactions between the different lists. And in order to really estimate the number that is outside of any of these lists. Okay? So the idea is that we have the hospital list. So we have the list of those that were killed reported by the hospital up to June. And at that point, and we have the ID, the name, and all of this information. We also have a survey where people have entered the data of their relatives that were killed. So this is 2 listing, right? We need a 3rd listing. So what we ended up doing is we ended up scraping the internet for names of people that were killed in Gaza, using looking at name, gender, where they were killed, how they were killed, on Twitter, on Instagram, now it's not called Twitter anymore, on X, on all the different platforms. And basically, we looked at these names, and the idea behind it is to look at the overlap between all these 3 lists to determine how many were outside any of these lists. And so just a bit of starting with a bit of a demographic and looking at prevalence or proportions. So the 3 lists, there was a lot of mortality at the beginning, and then the mortality decreased, and we know that it was not consistent. There were more different distribution of mortality. As time moved, some escalation happened, and then mortality went back up. Actually, it went back up after June 2024, but that we stopped the analysis at that point. And what we also looked at is gender differences and gender and age differences between the lists. And what's great about this is that you could adjust in the model for these variables also. And so what we did is we took the hospital list, we overlapped it with the social media list and with the survey list. And the idea behind it is that you look for the names, and that takes a lot of time because you look at how people write same name differently on different lists. And this is very important for this, because if you do not think they're the same person, and actually they are, you'll have a biased result, right? So you just need to be, we did a lot of manual actually at a certain point. There are things that help you a bit, probabilistic linkages and some of these methods, but reality is you spend a lot of time doing manual also checks. And different combinations of the names to come up with really how many are overlapping in the 3 lists. And you generate basically a data set that looks something similar to this, that the first person is on the first list, the second person is on the survey list, and for example, the last person, for example, is on all 3 of these lists. Okay, so basically to see how the data actually would look like. And then you run different models to come up with the really estimates outside of any of these lists, okay? Now, people before used to pick one of the best fit models, but we have also tried to weight this number using the posterior probability to come up with actually how many were captured outside all of these lists using all the different models where we looked at different interactions. So you look at between hospital and the survey list and so on. And we actually find that around at that point in June 2024, around 64,000 people were killed, which represents around 3% of the Gaza population, which is 1 in 35 people who were killed. Now, there is an unpublished study that basically is under peer review, but has been put online for people to see, that did a survey inside Gaza. And they find a very similar number, actually, which is actually a 40% underreporting from the Ministry of Health. So at that point, the Ministry of Health, for example, in June was saying around 35,000, and the reality was 64,000. And so the same thing in this, Mike's Paget has released that, but it has not been published yet. I hope so soon it will be. It also shows a very similar underreporting, which also shows that two different methods, one of them was capture-recapture and one of them was a household survey, which is not really possible to do in a lot of wars. And if you look, there's quite a lot of literature on the Iraq and all of that show, like, these two methods show similar underreporting inside Gaza. And so the second thing we also did is actually look at mortality rates. And basically, this is the age and the y-axis, and then you'd have males in purple and females in green. And you'd find that the mortality rates actually is quite high for both gender and ages. But also that if you look at the rate ratio, so as compared to before the war, so children that were 0 to 14 years old were 24 times more likely to be killed. And so, but as an overall rate ratio, it was 14 times more likely to be killed in Gaza. And so, of course, this actually like shows the scale of this war. But actually, what we also tried to do in one different paper where we looked at the mortality patterns is we took the mortality pattern, which is in dark, which is the one in Gaza currently, and we looked at other UNIGMI mortality rates of conflicts. So this is the dotted lines where actually what other conflicts showed in terms of mortality by age and by sex. And if this is the pattern for conflict, this would be the pattern for an earthquake, for example. So the earthquake, you'd have a lot of mortality for under 0, like under 1, and then you'd have a very high mortality for over. And in previous genocides, where actually we could see that the mortality of Gaza and other previous genocides. So what we wanted to see is like, how does this mortality in Gaza actually differ from other conflicts? And so that's in terms of mortality. The other big thing we did in terms of mortality was actually we looked at projections. So a lot of the work I've talked about was actually done in June because of the questioning of the numbers and all of that. But the reality is that when they first hit the first hospital, there was a lot of discussions about what happens not only for traumatic injuries, but what happens for women who are pregnant, who need access to care. Actually, a lot of them delivery would be fine, but if she has a hemorrhage, her likelihood of dying would be very high. And so, because there's no access to hospital. So we actually did projections of what would happen in different scenarios. And that was actually going back in time to talk about, yes, wars kill by looking at aerial, ground, and bombing, but also war killed for shelter, disruption of healthcare, insufficient water and sanitation, insufficient food, so the indirect effects of the war. But one big thing also that is a big cause of mortality in wars is also epidemics. So if there's an epidemic that happens, so a cholera outbreak, a polio outbreak, how many people will die? And actually, this was an attempt, actually, to my knowledge, the first one to try to do in the middle of, at the beginning of the war of, okay, from February till August 2024, how many people will die if we have different scenario, which was a ceasefire scenario, a status quo scenario, and an escalation scenario. And the escalation was actually the incursion of Rafah, which actually happened. So a lot of these projections is actually sad to talk about, because when we released them in February 2024, and a few months after, there was actually an escalation and an incursion in Rafah, but also there was polio outbreak. And so it's like, and I will talk about malnutrition, but it's like we could see how this is going to unfold. It doesn't take, as epidemiologists, we know where different countries have different vulnerability. And Sudan would be very different from, and Yemen would be very different from Gaza, where there was a big burden of NCDs in Gaza. Whereas infectious diseases was not really dominant at the beginning of the war. Even now, it's not as prevalent as when you talk about Sudan, for example. And so we came together and we said, okay, let's do projections of traumatic injuries. So those that are killed, but directly, but those that also get an injury and do not get treated and go to the hospital because there is no treatment, there is no medication, there is no, and at that point, there was a lot of this happening. What we didn't do is actually look at traumatic injuries with malnutrition, which also increases the mortality. So the models are not perfect, and I'm the first one to say that, but they were a first attempt to try to see what would happen if we have a ceasefire in terms of mortality, what would happen in a case of escalation. And so if there's an infectious diseases, and we looked at them as endemic and epidemic, where epidemic, we looked at cholera, polio, if there is a polio outbreak, if there is a hepatitis A outbreak, and so on. For maternal and neonatal health, we looked at if a baby does not have access, a premature baby does not have access to NICUs, and what would happen. And the hardest one was actually NCDs, where I think a lot of work could also continue happening. And if anyone is interested, I'm happy to discuss. But in fact, to look at what would happen in case of a heart attack and you don't have access to a hospital, what would be the mortality and how much is going to increase? Now, the problem with infectious diseases, with NCDs, I mean, is that you have the whole like type 2 diabetes and hypertension and the dynamic, and some of modeling these we did not do at all. And we knew that there were cases of COPD that were dying, and we knew that this is pulmonary diseases because mainly the high levels of debris and the lack of oxygen that we were hearing. But we were not able to put these in a model, first, mainly because there were no studies that we could use the effect size to try to see what happens when you do not get oxygen and what's your likelihood of dying. And whereas in NCDs, we were able to find very old literature, but also some literature in like earthquakes and some literature in tornadoes and some of this to try to estimate these models. There's a lot on in the US actually also, and when a tornado happens and chronic kidney disease do not get treatment, what happens? What's their mortality? And so we could find some of this literature. So the idea behind it, and this is a snapshot of what you would put, is to say, okay, in a status quo, we know from different people that the levels of water were 6 liters per person per day. In a ceasefire, hopefully it will increase to 20. In an escalation, it will go down. And so you would model what happens in the 3 different scenarios. And the same for toilets per people. And that actually impacts a lot the infectious disease model, right? Whereas access to care, so access to hospital, let's say this is the last one where we looked at, actually impacts a lot NCD patients, where in the status quo, we knew that around 10 to 15% were able to access inpatient services, whereas in an escalation, it would actually be lower, and in a ceasefire, it would be high, but not as high as it would be because nothing is going to be back to normal. So we did the projections. What we did for infectious diseases is actually we did a dynamic model where we looked at immunity because there was very high immunity for vaccine coverage. So it was actually around 100% before the war. And we looked at what happens if the vaccination coverage is going to decrease. We used a lot of data from the literature, but also used expert elicitations to come up with reproduction number and case fatality ratios with different scenarios that we presented to experts. And one of the key elements that came up is actually the element that if a cholera outbreak will happen, it will have a very high mortality. And regardless of the scenario, whether it's a ceasefire, whether it's status quo or an escalation. Hepatitis A, it actually happened as an outbreak, but it wouldn't cause as much mortality. And actually, that's what we also see. But there was a hepatitis A outbreak. The scariest one was actually polio, because we could see that mortality would be quite high if a polio outbreak happens. And what happened in Gaza, sadly, a few months after there was a polio outbreak, but then which is good, that then a lot of the UN, there was a lot of pressure into vaccinating and coming up with a vaccine campaign in order and to detect polio and to vaccinate against polio. The thing is that we were when they were trying to do the round 2 of the vaccines, some of the kids were actually dead because of the bombing instead of dead because of the polio. So there was this that was actually happening on the ground. So mortality in Gaza, especially at a very rare point, was mainly due to the war, mainly due to the bombs, and yes, you could vaccinate, but you could put basically a Band-Aid on a bleeding wound, but the wound is still bleeding. And so this is what was mainly happening. Now, in terms of maternal and child health and nutrition, maternal and neonatal death, this is also the only model that actually is available that we didn't have to build from scratch, which was the LifeSafe tool. It has its own positives and negatives, like all models, but at that point we were building models for infectious diseases, for nutrition, for NCDs, and so we used this model for the LifeSafe tool in order to look at what happens when women do not have access to antenatal care, when they don't have access to hospital, which is actually the main reason for mortality for women and newborns, and decreased food security and so on. And the idea behind it is the same idea, is that around 80% were actually delivering in a hospital. 70% would deliver in a hospital if there's an escalation. 90% would deliver in a hospital if there's a ceasefire, knowing that not everyone will go back to delivering in a hospital, because even with a ceasefire, the whole the system has collapsed. And so we do the projections, and in terms of numbers, the numbers was the highest for neonatal death, actually, for the escalation, which is in purple, which the gray one is actually before the war. What would have happened in terms of mortality? Because we know there is neonatal death that's going to happen. And so this was the gray one. And then we had the escalation in purple. And in terms of maternal mortality, it would reach around like around here we were like 40, I think. Yes, 40. But there was also now a survey that we've done in Gaza of all the pregnant women that were pregnant on the 7th of October, to try to follow them up and see what happened to their pregnancy. So they were pregnant on the 7th of October, and they delivered right after. And we see very similar numbers to these projections, actually. And finally, talking about NCDs, this was the challenge. One of the things is to say, okay, you are a type 1 diabetic, you don't have access to insulin, what would happen? Now, actually, I want to say a bit of a reflection, because when we did this one, we were really focusing on insulin a lot. And I was like, and I found literature and talked to a lot of doctors to try to see like what happens when a type 1 diabetic does not get insulin. Fast forward a year and a half after, or a year after, I'm a nutritionist, and I worked a lot on malnutrition, and I'll get to the malnutrition section. And in diabetes, the discussion was mainly, we want sugar. And it was actually the lack of sugar and the price of sugar that was very high that caused actually people to go into actually, there were nurses that were calling us and trying to ask us if they could use the RUTFs, which are the food that you give as supplements that are basically based on peanuts, if they could use that for type 1 diabetic. And we were like, it does not have sugar, you need sugar. And so I think in retrospect also there is that aspect that we didn't also include in the models, for example. But the whole thing is like what happens when insulin does not exist, but actually what happens when the price of sugar becomes so expensive that no one can access it, and it becomes like gold for type 1 diabetic. And so there was chronic kidney diseases, so there was a lot of discussions about them because they need access to dialysis, heart attacks. And actually, if you look at before the war in Gaza, we started, like I did a survey in 2020, okay, looking at NCDs in Gaza to try to model how to best give assistance to decrease NCDs in Gaza. Because reality is that around 80% of people that were over 40 were overweight and obese. The reality was that the main causes and the main burden was actually heart attacks and hypertension and diabetes. And that was like the last study that was done before the war to showcase how much NCDs was actually dominant in Gaza. And what I was arguing for is a change in the assistance module in Gaza. So I was trying to say, instead of giving this much ration of sugar, you need to give more fruits and vegetables. How silly am I? Because the reality was that that was not the case. Fast forward 2 years. And so I'm giving a bit of a reflection, but it's just some of the stuff really sometimes makes you wonder what we're doing. But sorry for that interruption. So what we did is we modeled what happens when a chronic kidney dialysis does not happen, and what's the survival versus and how long would they survive if they get or not get a treatment. And so the main mortality was type 1 diabetic if they don't have access to insulin. We also had ischemic heart diseases, and mainly it will continue with the ceasefire because a lot of the doctors and a lot of the doctors who know these skills actually either left or were killed or they were very limited. So there's not enough doctors anymore to do that. So there is a big detail about all of this. But just to say that we released this, and that was in February 2024. And in August 2025, we project that around like 125,000 would die if the escalation happens, whereas if a ceasefire happened, around 51,000. Now, the argument was a lot like how many lives could be saved. And this is a visualization that visualizing Palestine with Jewish voices of peace they did based on the data that we projected to show how many people would die if we don't have a ceasefire. And they really show like in terms of like maternal and newborn and how many lives could be saved, And the big one was actually traumatic injury, like the big mortality in Gaza was the bombing. And so if you allow me in the last 5 minutes to talk a bit about the starvation, and because I'm a nutritionist, and before the war, I was working on electronic health records of Palestinian refugees in all 5 settings where they live: Lebanon, Syria, West Bank, Gaza, looking at rapid weight gain. So how does children growth happen in terms of that leads to overweight and obesity in children. So I had a cohort of Palestinian refugees where I was mainly looking at their growth, and I was looking at overweight and obesity as an outcome. And when it all started, we were in discussions, and I was like, wasting does not, what are you talking about? We don't have wasting. Even when we talk about some of the Syrian refugees that came to Lebanon, we had some cases of wasting. We do have cases of wasting in Syria at a certain point, but it never was to the scale what we saw in for example, in Sudan. And so the reality was that this is the end of the same spectrum. So wasting is the end of the spectrum, and overweight is the other end. And I was we were mainly talking in the region about overweight and obesity. And what happened in the past 2 years actually shows how quickly a situation can flip. And And this is where I want to talk a bit about the starvation and what happened in Gaza. So again, the same thing as mortality. There's a bit of discussion and a lot of discussion about numbers and about how many calories were available in Gaza. So Oxfam, for example, says that around 240 calories are available per day for a person, okay? Whereas another study showed that they were around 3,100 calories. So it's fine. There is no problem in calories in Gaza. We have enough calories. So there was a lot of narratives. And like all wars, there's always different narratives that come together. And so the discussion was like how many calories was really available. So how is famine classified? So the famine is classified by looking at 3 different indicators. The first one is food availability. So how much food is available in calories, or in food insecurity, which is a indicator or tool that you collect. Acute malnutrition, which is what I was referring to as wasting, is when you see children that are really thin, and sometimes you see them with kwashiorkor and marasmus, depending on how it will present as acute malnutrition. And the third indicator you use is mortality, which is always very hard to collect. And so using these 3 indicators, there's a classifications of famines, but also classification of food insecurity that the IPC uses. And so what did we do? We took data from humanitarian warehouses, which was WFP, World Food Program, and UNRWA, which were the 2 main providers of assistance in Gaza. So they had warehouses and warehouses of food, and actually they were stocked right before the war, okay? And so we knew how much rice and everything was in these warehouses. Then we had private storage stocks from WFP data, which is the World Food Program, and also on the household stocks. Now, this is a lot of assumptions, okay, for the household stocks mainly, because you would have to say, okay, at what point you start to see really household stocks, but there was a surveys that WFP does on this. During the war, what we did in order to estimate calories is we used all of this data that was available before the 6th of October. Then we looked at agricultural land, so how much agricultural land was decreasing over time in Gaza. And FAO actually does satellite images to showcase how much the agricultural land was decreasing and how much food was available from this. There is the trucks, and UNRWA was actually publishing this data up to a certain point when they stopped them from publishing it. But we knew exactly, not only we knew how many tons of food was going into Gaza by tonnage, okay? And that is not possible to do in Sudan. We were able to do that in Gaza because everything was very well contained and tracked, and we were like coming and doing that type of an exercise of how many kilocalories a person eating today in Sudan is very different than when you come and do that in Gaza. And finally, there was this famous airdrops and boats that they built, and then it went away. I want to ask you if you can guess how much of all the food that went into Gaza, so out of all the food in Gaza, what's the proportion of, in the north of Gaza, what's the proportion of calories that came from the famous airdrops that a bit of the UK actually paid for also? Less than 5%. What would be? Around 3%. And I'll show you this. Actually, like, all governments were so proud of how much their airdrops they're doing. They had all this data like published in their website. So like you just open the US Air Force, you'll find them. The Jordanian, you'll find them. The UAE, you'll find them. The UK, everyone was very proud that they are dropping food in Gaza. Yes, the airdrops of Gaza was 2%, 3%. So the airdrops of Gaza in the north, basically, because they mainly happened in the north, were contributed to 3% of the intake. So it was cheaper for everyone to get in the food trucks, by the way. And this paper was just published, but we have had a preprint before, and we have also used a lot of this data. But just to showcase that was also the first round, and of how much calories was happening in Gaza. So this was the beginning of 7th of October and onwards. And I know I have to finish in 1 minute, But what we see is actually a decrease in calories available in Gaza, in the north mainly. And that was in February 2024. Now, what happened in February 2024 is, and March was actually the killing of the World Central Kitchens. So with the killing of the World Central Kitchen staff, the food opened by one phone call. The crossing happened and the food entered. And this is directly reflected in the data of how much calories are available in Gaza. So in fact, it reached a point where at a certain point, the calorie was around 1,200. And then actually FAO has continued this analysis later on to actually show in the most recent, what happened recently, is actually how much it also decreased to around 1,000 in the north of calories. But why is this important? This is important because the yellow line, which I don't think you can see well, showcases how much really a population needs, which is around 2,100, but could be adjusted based on how many kids there are. So, kids would eat less, and you get all these arguments. So in fact, it's like 1,090 if you want to be 2,090 if you want to be very precise. So we were able to track how much calories was going into Gaza, but what we also did was actually project what would happen into the weight of the people. So in nutrition, there is the therapeutic food that I mentioned. So these RUTFs, or the plum peanuts, they call them also, that actually you give as interventions for calories. What would impact also weight would also be infectious diseases. So the more infectious diseases, and the dynamic between malnutrition and infectious diseases is quite well documented. So how all of this would impact the weight of the children, including how much food is available for children. So what we did is actually we took a model for overweight and obesity, and we modeled what would happen the opposite. So by including also therapeutic food, infectious diseases, and what's happening in terms of infant and young child feeding in Gaza. So in terms of disruption of breastfeeding and all of that. Now, this is an attempt to try to model malnutrition. And I think that we'll be moving forward with more validation into all of this. But I do not think I have a lot of time to go into details, so I will skip this because just to say that we were able to model like the acute malnutrition that increases in Gaza at a certain point in March, and that actually in the north mainly was visible. But that at the same time was also reflected in some of the data that came from the north, showing around 30% acute malnutrition, and then a drop when the food became more available. That was before the most recent cuts in food. So what happened in food is that there was a clear yo-yo that you could clearly see that the tap was opening and closing. And so actually we used a lot of that way to look at what's happening. But one of the big coping strategies, which I didn't show here, but is actually what made a huge differences in Gaza, is the fact that when the parents were not able to anymore save their calories to feed their kids. So what happens in food insecurity is that a lot of the time people first compromise on quality of food, then they compromise on quantity, but what they do as coping strategy is they stop eating, so they feed their kids, or they eat less. So we were able to include these in the model, actually, to say how much parents are able to sacrifice their food for their kids. And once we started to hear from Gaza, this whole issue about coping strategy of parents not able to feed their kids is when we saw this huge acute malnutrition increase. And this is just to show that some of the work we've done in the Famine Review Committee is actually to showcase that, in fact, in May and June in the past year, acute malnutrition was actually not that high. But once we reached this point, we have a normal distribution, sort of an exponential increase in acute malnutrition in the north. And that actually models in reality into what we saw in the modeling, when we do the modeling where we see a peak that happens in acute malnutrition. Now, of course, these models need validation, and we are working more on trying to use this in reality to try to understand, okay, what's the acute malnutrition prevalence in Sudan and so on, based on data about how much calories available, how much interventions are available, and so on. And so finally, this was like where in July and August, the Famine Review Committee classified Gaza, north of Gaza specifically, actually, as with a very high evidence of famine. And I just want to say all of this to say I showed data a lot, and I talked about mortality, which we have used to showcase what's happening and for accountability purposes, for also the cases of the what's happening in terms of the court cases that are now going to hopefully happen, to showcase what's happening in terms of mortality and document, but also in terms of famine and how the situation could decrease a lot. And all of that is data, but we all know, and I don't like to show a lot of the devastation of what's happening in Gaza, but just to say that behind all of this and behind all of this data scraping and is people and stories and lives of people that were killed and people that are still suffering as we speak. And I think one of the big things that I try to show is that even with a ceasefire now, we still have a system that's completely crumbled, that if a cholera outbreak happens, we will have a very high mortality. So it's just to bring back to the story to what's happening in people in Gaza. And so thank you so much. And sorry, I took 5 more minutes of your time.